This video begins with a brief overview of health history taking, followed by examination of the sensory system, including assessment of pain, temperature, light touch, and vibratory sensations, as well as position sense and discriminative sensations. Anatomy of reflexes, grading reflexes, and assessment of reflexes. We conclude the video with tips on describing your findings. You will see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings, or you may discover normal variations or abnormal findings. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you'll record the patient's chief complaint along with common or concerning symptoms. Common or concerning symptoms relating to the nervous system and specific to the sensory system and reflexes include numbness or abnormal or loss of sensations, and increased sensitivity to pain. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. To prepare for the sensory system examination, let's review its basic components. The sensory system includes the sensory receptors and nerves, sensory tracts in the viscera and limbs, the spinal cord, the thalamus, and the sensory cortex of the brain. To help localize neurologic lesions, the body may be mapped into dermatomes, which are skin bands innervated by sensory roots from different levels of the spinal cord. When assessing the sensory system, plan to evaluate the patient's sensations of pain, temperature if indicated, light touch, vibration, position, and discrimination. Begin the sensory examination by assessing pain sensation in arms, legs, and trunk. To do this, first warn the patient, then use the sharp end of a broken cotton swab stick, a previously unused safety pin, or some other suitable tool. Ask the patient to close his eyes. Then, starting with the arms, test scattered areas, occasionally substituting the blunt end for comparison between sharp and dull. Compare sides and distal and proximal areas. Continue the evaluation of pain sensation with the legs.
Sharp, dull, sharp, sharp.
Next, test the anterior trunk.
Now I want to fold your gown down. Just scoot up a little bit here. Put your arms out of it. Okay, put your arms right back here at your side. Same thing, just tell me sharp or dull. Okay.
If you detect any abnormalities, evaluate the posterior trunk.
Dull.
If pain sensation is abnormal, test the patient's response to temperature.
Sure. All right, good.
Next, assess light touch with a cotton wisp. Check the patient's arms and leg.
All right, close your eyes again. Now I'm going to touch you with this cotton swab to check light touch. If you feel it, you say now. Are you ready?
Yes. Now. 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 Now.
Then check the
Now.
patient's trunk.
Now.
Does it feel the same
Compare sides.
here and here?
Same.
Is this side The same as this side?
The same.
And compare distal with proximal areas.
Same as this?
Same.
And this? The same as this?
Same.
Next, assess vibratory sensation using a lightly vibrating low-pitch tuning fork.
All right, I'm going to test vibratory sensation next. Close your eyes again.
Have the patient close his eyes, then place the vibrating fork firmly over the finger pad
What do you feel?
and ask the patient to
Vibration.
tell you what he feels. Ask the patient to tell you when the sensation stops. Then stop the vibration.
It'll stop.
Okay,
Now test the patient's other
right
hand.
over here.
Normally, vibratory sensation is intact distally. If it is diminished, proceed to more proximal areas, such as the forearm.
Okay, now.
When assessing vibratory sensation of the lower extremity, start with the big toes. Compare size. If vibratory sensation is diminished, check more proximal areas.
In this foot, you feel
Keep in mind that distal vibratory sensation may normally decrease with age. For the next part of the exam, test position sense.
Next, I'm going to test position sense in your feet.
Hold the sides
and
of the
in your
patient's
hands.
big toe with your thumb and index finger. Avoid touching the other
Move
toes.
it up,
First, move the toe up and down,
left.
identifying each
or
position
right.
as the patient watches.
You close your eyes and tell me
Next,
which direction it goes.
ask the patient to close his eyes and identify the direction of motion.
Left.
Move the big toe up
Right.
and down in an irregular sequence. Then compare with the big toe on the other foot.
Same thing. Are you ready?
Yes.
Here it comes.
Up. Down. Right. Left.
In a similar fashion,
And that's
again with
right.
the patient's eyes
Close your
closed,
eyes.
test position sense in the upper extremities using a finger on each of the patient's hands.
Down. Left. Right.
Finally, test discriminative sensations by assessing stereognosis or object identification, which is the primary test. If necessary, also test number identification, 2-point discrimination, point localization, and extinction. You will perform each of these tests with the patient's eyes closed.
Keep your eyes closed. Now hold out
To
your
test
right hand.
stereognosis, place a familiar object in the patient's hand and ask him to identify it.
Feel that object and try to identify it.
It feels like a coin.
Good.
Repeat the procedure on the other hand using a different object.
Feels like a key.
Good. You can open your eyes now.
To test graphesthesia, or number identification, use a blunt object to draw a large number on the palm using a single continuous stroke.
Now I'm going to test number identification. Close your eyes. And on the palm of this hand, I'm going to write a number facing you like on a chalkboard. You tell me what it is.
The number should face the patient, not the examiner.
3.
Right.
Test one palm, then the other.
Now the same thing in this hand. Tell me what this number is.
A 5.
2-point discrimination is tested by asking the patient if his finger pad has been touched in one area or two. Using two ends of an opened paper clip or the ends of two pins, repeatedly touch the patient's finger pad with the 2 points at the same
I'm gonna do
time
another test of
and with
sensation
1
in your
point
fingers.
occasionally. Be careful not to cause pain.
Is this paper clip? I'm going to touch your
Ask the patient to identify if he's being touched with 1 or 2 points.
2.
Then reduce the distance between the points
All right, close your
so
eyes.
that you can determine the minimum distance at which the patient can identify 2 points. On the finger pad, the distance should be less than 5 millimeters.
2. 1.
I'm going to do another test of sensation now. Let me fold you
To test
down.
point localization, touch a point on the patient's skin. Then ask him to open his eyes and point to the place touched.
Put your hands right here. I'm going to touch you on a part of your body with your eyes closed. After I do, then you open your eyes and point to where I touched you. Are you ready?
Yes.
All right, close your eyes. Okay. Where did I touch you? Close your eyes again.
This test is especially helpful on the trunk and legs.
Where did I touch you? Correct. Okay, close again. Where did I touch you? Now I'm going to touch you on your left side, your right side, or both. And you tell me whether it's left, right, or both.
Okay.
Ready?
Yes.
Close your eyes.
To test double simultaneous stimulation, use your fingertips to provide stimulus on either one area of the patient's body or in two areas simultaneously. Normally, the patient should be able to identify whether your stimulus was on one side or on both sides.
Both.
Good.
Before we assess the deep tendon reflexes, let's see how and where they occur. Deep tendon reflexes are involuntary monosynaptic cord reflexes arising from the stimulation of partially stretched muscle fibers. This sudden additional stretching sends impulses along afferent nerve fibers to synapses in the spinal cord. Then efferent nerve fibers carry the impulses back to the muscle fibers, causing them to contract. Interruption of these monosynaptic arcs anywhere along their paths will cause loss of the reflex. Each deep tendon reflex corresponds to a specific spinal segment. The ankle reflex primarily relates to S1 and L5. The knee reflex to L2, L3, and L4. The brachioradialis to C5 and C6. The biceps reflex also to C5 and C6, and the triceps reflex to C6 and C7. Note that these ascending reflexes follow the numerical order 1 to 7, which may help you remember them. When assessing deep tendon reflexes, grade them on a scale from 0 to 4+. A grade of 0 reflects the complete absence of movement. 1+ indicates a somewhat diminished reflex that shows movement only with reinforcement. A 2+ reflex shows greater movement than 1+ and is an average normal response. A 3+ reflex is brisker than average, but not necessarily abnormal. A 4+ reflex is a very brisk hyperactive response. It is accompanied by clonus, a rhythmic oscillation between flexion and extension. Hyperactive reflexes suggest central nervous system disease. Begin assessing deep tendon reflexes by testing the biceps reflex. The patient's arm must be relaxed, partially flexed at the elbow, and positioned with the palm down. To stretch the muscle, depress the biceps tendon with your thumb or index finger. Strike your thumb or finger briskly with the reflex hammer. You should feel the biceps muscle contract and see flexion of the forearm. Here you see a 2+ response. To assess the triceps reflex, flex the patient's arm at the elbow with the palm toward the body and pull the arm slightly across the body. Strike the triceps tendon above the elbow. Watch for contraction of the triceps muscle and extension at the elbow. Here you see 2+ responses. To elicit the supinator or brachioradialis reflex, the patient's forearms should rest on the lap with the palms down and externally rotated slightly. When the patient is ready, strike the radius 1 to 2 inches above the wrist. Observe for flexion and supination of the forearm. Again you see 2+ responses. If you need to accentuate or reinforce arm reflexes, ask the patient to clench his teeth throughout the testing.
Now I want you to clench your teeth together hard when I say, just as I hit the reflex. Ready? Clench your teeth. Relax.
To test the knee reflex, locate the patella tendon in the patient's flexed knee. Briskly tap the tendon just below the patella. Feel for contraction of the quadriceps and look for extension of the knee. This patient exhibits a 2+ response. To test the ankle reflex, extend the patient's legs somewhat at the knee, dorsiflex the ankle, and strike the Achilles tendon. Feel and watch for plantar flexion. A 2+ response is seen. Repeat your assessment of knee and ankle reflexes on the opposite side. Dorsiflexion of the big toe, or a positive Babinski's sign, is a pathological response which, as simulated here, manifests itself in dorsiflexion or upgoing of the big toe in conjunction with fanning of the other toes. To test for plantar response, stimulate the lateral aspect of the sole of the foot from the heel to the ball, curving medially across the ball. Use the lightest stimulus that will provoke a response. Note this patient's normal response, plantar flexion or downgoing of the toes. If the leg reflexes are symmetrically diminished or absent, use reinforcement.
I want you to put your hands together like this. When I tell you to pull, then pull hard, but wait till I say.
Have the patient lock his hands and pull just as you test the reflex.
Now relax.
If leg reflexes seem hyperactive, test for ankle clonus. To do this, move the foot up and down a few times, and then sharply dorsiflex the foot. While holding the foot in dorsiflexion, look and feel for sustained rhythmic oscillations. A few beats may be normally present. For a patient who cannot sit up, all of these tests can be performed with the patient lying down. Biceps reflex, triceps reflex, brachioradialis reflex, knee reflex, ankle reflex, plantar response, and ankle clonus.
I want you to lie back on the table now, please.
To test the abdominal reflexes, place the patient in the supine position. Lightly but briskly stroke each side of the abdomen above and below the umbilicus. You should see contraction of the abdominal muscles and sometimes deviation of the umbilicus toward the stimulus. If you suspect meningeal inflammation, test for meningeal signs. With the patient lying down, place your hands behind the patient's head and flex the neck forward until the chin touches the chest if possible. There should be no resistance or pain. As you flex the patient's neck, watch his hips and knees. Normally, they should remain relaxed and motionless. Hip and knee flexion with this maneuver is a positive Brzezinski sign. Finally, flex one of the patient's legs at the hip and knee, and then straighten the knee. This action normally produces discomfort behind the knee during extension, but should not cause pain. Pain and resistance to knee extension is a positive Koenig sign. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. For a healthy patient, your write-up might include sensory, pinprick, light touch, position, and vibration intact. Reflexes, 2+ and symmetric, with plantar reflexes downgoing. To summarize, the examination of the sensory system includes assessment of pain, temperature, light touch, and vibratory sensations, as well as position sense and discriminative sensations. Examination of the reflexes includes assessment of the biceps, triceps, brachioradialis, knee and ankle reflexes, and assessment of the plantar response, or Babinski's sign.